can go to the next slide. Next slide, please.
There it goes. Sorry about that. Okay.
No, it's fine. Yeah, so I'm a geriatrician, and then I primarily care for older adults in their homes, and so I like to start with to kind of ground my comments in a patient's story. So Miss B is one of my patients that I cared for a few years ago. She's a religious woman. She was unable to attend church when I was caring for her. She lived in a senior housing community or building, and she had minimal contact with others. She didn't talk to her neighbors. She didn't, though she had children, she wasn't in close contact with them. And she had various mental and physical health issues that led to her having frequent hospitalizations. And of my interaction with her, though she had many health challenges, I noted that she really enjoyed our home visits, and she expressed that. And during holidays, always greeted with a card, and that was true for me as well as other members of our team. So I can't just claim that it was I'm such a great physician and great person that she enjoyed my presence so much. It was every member of our team that she enjoyed the in-person contact with. And so I noted with her uh, that she'd struggle in the absence of people's contact, and that's why I think one of the reasons she described symptoms that led her to go to the hospital, because she got in-person contact through those interactions. And next slide, please. And so I begin to realize after multiple visits with Miss B that she was isolated and lonely. And I, at that juncture in my career, realized that I wasn't really equipped with any tools to actually do anything about her isolation and loneliness. And so I got very interested in this during this time. Next slide. And one of the first things that I came across when I was doing research was this quote, and I found it particularly fascinating and profound. The statement that social relationships, or the relative lack thereof, so that's individuals who don't have social relationships or who may be isolated, um, it constitutes a major risk factor for health, rivaling the effect of well-established health factors such as cigarette smoking, blood pressure, blood lipids, obesity, and physical activity. So, suggesting that our relationships or their absence of them has an impact on our health and well-being, similar to things that I would say that most physicians would say we should be trying to address. Next slide. And so I mentioned it a few times, but I think it's important for us to define it here. And so social isolation is the objective lack of or limited social contact with others. And this definition comes from the National Academies of Sciences, Engineering, and Medicine report that came out in early 2020. Next slide. And also in talking about social isolation, I think it's important to also mention loneliness, because these terms are often discussed. Sometimes in parallel, but sometimes people are using them interchangeably. So loneliness is the perception of social isolation or the subjective feeling of being lonely. Next slide. And so, as I've noted previous in the last slide, that it's important to distinguish these two. So here, driving at home, social isolation is objective. It's being isolated. It's like being in a state of quarantine, whereas loneliness is a subjective perception. It's feeling isolated. Social isolation exists when there's low levels of social contact, whereas loneliness, there's a mismatch between actual and desired social relationships. Social isolation is not necessarily unpleasant. Some people may prefer this, whereas loneliness is an emotionally distressing and unpleasant state. Social isolation may be this chosen solitude, whereas loneliness exists when there's this low sense of control or choice. Next slide. And so, in thinking about how our connections, how does isolation or the presence of connections with others actually impact health? We are fortunate to have people who've dedicated their careers to really understanding this. And Julianne Holt Lundstedt is one of the people. And in this model that she's put forth, it describes or points out direct and indirect pathways in which social connection or disconnection actually manifests itself and impacts morbidity and mortality going through behavioral, biological, and psychological pathways. So really getting at how does our connections get under our skin to actually lead to certain health outcomes. Next slide. And so, in going forward and just talking about the mortality data very briefly, in 2015, Julianne Holt-Lundstedt published a meta-analysis that essentially incorporated 70 studies from populations around the world. It's about 3.4 million participants that were included in these studies that made up this study. And in this data, they found that individuals who are lonely, isolated, and living alone all had higher likelihoods of mortality or death. Next slide. And so, one of the conclusions that her work has identified, as well as many other studies, is that social isolation, loneliness, or the absence of our connections have robust effects on mortality relative to other important risk factors, like I previously mentioned. And also, this finding, in terms of its impact on mortality, is consistent across gender, health status, cause of death, or country of origin. And these findings are true for both objective and subjective indicators of social connections. So that's both loneliness and isolation are important in terms of its mortality risk. Next slide. And so, in thinking about, we're interested in other things other than mortality, right? We're interested in morbidity and other impacts. And so, we're in terms of physical health. We know that individuals with cardiovascular disease and diabetes, immunologic states, when they are isolated or lonely, we know that there's this physical health burden associated with those conditions. We also know that individuals, there's studies that support that individuals who are isolated and lonely, they have higher levels of depression, and also variations in terms of other behavioral health risk. We also know by important work that individuals who are socially isolated cost Medicare an additional $6.7 billion each year. And then lastly, I'll point out here, we know that there's also impacts on on the cognitive health of individuals who are socially isolated or lonely. Next slide. And so for my own work, particularly in older adults, we know that about 1 in 4 older adults are isolated, and that there are resources that we can connect to that may mitigate some of this risk. But it's important for us to know that 1 in 4 individuals over the age of 65 are isolated. Next slide. But in addition to older adults, there are other populations at risk, and those are individuals who have lower incomes, individuals who are disabled, who live alone, individuals who are part of immigrant communities or the LGBTQ communities, individuals with functional or sensory deficits or language differences. All these factors can put people at risk for isolation and loneliness. Next slide. And so I alluded to this report before, and I think it's for anyone who's interested in this area and wants to read more, the National Academies of Sciences, Engineering, and Medicine report, which came out in early 2020, focuses on opportunities for healthcare systems. And so from this report, we essentially have the findings are vast, but some of the seminal things that I would like to point out is that we do need to develop a more robust evidence base. We also need to translate our current research into actual practice. We need to improve awareness. So this opportunity today is a way that we're doing that. We also need to strengthen ongoing education and training on what we understand and we might be able to do to evaluate and support individuals who are isolated and lonely. And then we need to strengthen ties between healthcare systems and community-based networks and resources. So that this is a great document. It's clear. There's a nice executive summary if you don't have time to read the whole thing. And then there's recommendations in this as well that I think can be useful for this audience. Next slide. Next slide, please. In thinking about how can we actually put some of this into action, I think it's valuable to think about a population health framework. And so we can think about primary prevention and then secondary prevention. So primary prevention is essentially we want to prevent people from, becoming isolated. So that's identifying patients who may be at risk for isolation and loneliness. And so those risk groups that we noted previously. And I would say this primary prevention, I think, is critical during our current pandemic times. Thinking about individuals who may have strong relationships with a loved one and may have lost a loved one that they're living with. Thinking about them during these times is an important way of primary prevention to prevent them from becoming isolated or lonely. And thinking about secondary prevention, it's decreasing the consequences for those who are lonely or isolated. So thinking about if we have identified someone as who is isolated and lonely, how do we mitigate those eventual risks that we pointed out before in terms of poor physical or mental health or morbidity and mortality associated with these things. So this requires that we screen and that we also understand and develop interventions that actually work to address loneliness and isolation. Next slide. And so I think we're fortunate that we had individuals back in 2015 who participated in the then Institute of Medicine report that focused on social and behavioral domains and thinking about how to emerge electronic health records. How can we use data from electronic health records to actually assess this problem? And so can you go to the next slide? This is within those domains, they recommended that we assess social connection or isolation using essentially measures that were part of the Berkman-Syme Network Index. And so these are questions that are brief that can be used to screen and then follow up individuals who may be at risk. Next slide. And so we also in the National Academy's report in thinking about this framework for how levels of responsibility in terms of how do we actually do something to actually intervene upon this problem. And this here example uses loneliness. And so I think we can there can be solutions at the individual level in our local communities and then broader society in ways that we can approach this problem. Next slide. And so I think amid COVID, our current pandemic, we have definitely gained greater awareness of the impact of social isolation and loneliness on our health. I think all of us have experienced isolation at some level potentially. And I think this has increased people's sensitivity to these issues. And of course, more work is going on in this area now. I think the other opportunity is that communities have come together to help one another to potentially mitigate isolation and loneliness. And then there's been an alignment of resources and communities to care. And then also I would say that there's been alignment in terms of scientific advancement. And we've seen that manifest itself in a variety of ways relating to the pandemic. We've also seen technology, telemedicine, and virtual interactions and content exponentially grow. And this is one way in which people, which can facilitate connections. And then I would say also, lastly, one of the opportunities of the pandemic is that hopefully it's given us who have potentially have the privilege of being with others to spend more time and attention and pay towards our relationships and our connections with those who are most proximal to us. Next slide. And so I think the way forward, I think, is focusing on strategies that embrace equity, strategies that also leverage policies, aligning public and private efforts. I would say starting proximal, thinking about who's close to us, in our family and our neighbors, those who we have connections with, and ensuring that those connections are strong, and that we ensure that these connections are meaningful because based on what we know, our relationships matter. I would say that there's been a group that formed before the pandemic, the Coalition to End Social Isolation and Loneliness. This is an organization that is putting forth policy strategies that I think are things that we should definitely think about when we think about policy solutions to address this problem. Next slide. And so addressing social isolation and loneliness will require that we think creatively and that we work together to end this important and burdensome problem that impacts older adults, but also other individuals throughout our society. Next slide. I always have to thank my mentors and acknowledge funders of my research, and thank you all for allowing me to be here today. That's all I have.
Thank you, Dr. Kojo.
Do I just jump in?
Absolutely.
Okay. Hi, everyone. My name is Ke-Xin Yu. I'm currently a PhD candidate in the University of Southern California School of Social Work. And it's an honor for me to be here today to share with you about what I know in terms of use technology to address social isolation. Next slide, please. So this is the overview of my talk today. I will first talk about types of technology. Technology is really an umbrella term and it encompasses a lot of things. So first of all, I want to show you some technologies that has been used to address isolation. And then technology adoption rate has been increasing among older adults, but there's also disparities that need to be discussed. And I will show you some evidence on the effectiveness of using technology to address isolation. And lastly, let's have a conversation in terms of technology is not a one-size-fits-all kind of solution. There are considerations for using technology to address diverse needs. Next slide, please. So what are we talking about when we're talking about technology? There are 4 domains that I think of in terms of technology. Perhaps the most generic one is the internet use, whether the older adult is online or not. That fact could be measured with just one simple yes or no question, but has predictive value in terms of the experience of isolation and loneliness. Now I will show you some evidence on that later. And another type of technology that is straightforwardly related to isolation, maybe is this kind of online interaction, the video calls, and these kind of Zoom meetings that we have been having during the past year. And I have been fortunate to involve in one of the study called iConnect. It is the internet-based conversational engagement clinical trial led by Dr. Hiroko Dodge in the Oregon Health and Science University. And that study is using these kind of video calls to target older adults living in isolation and try to prevent cognitive decline among these isolated older adults. I think this ties nicely to Dr. Kojo's presentation earlier in terms of the secondary prevention of the negative outcome, and ADRD, Alzheimer's disease and related dementia is a significant outcome of isolation and loneliness. Another aspect I'd like to highlight is mHealth tools. We are all familiar with the new development in these mobile apps that has been used for health purposes. For example, this is a project that I have been involved in is called IMTalk, Intergenerational Mobile Technology Opportunity Program. And this program called for college students as volunteers to teach type 2 diabetes patients to use mobile tools and to go online to search for information that would benefit their self-care. And we all know that health is a topic that we cannot avoid when we talk about older adults. A lot of the times, isolation and loneliness is a result of functional decline or health concerns. So if we can address the health and promote independent living for a longer period of time, isolation and loneliness may be able to be prevented. And lastly, I want to highlight the emergence in wearable devices and ambient technology. We've all been talking about the concept of smart home and smart environment. If we were to be able to develop an environment that older adults feel more safe to navigate, they would feel safe to go outside, that could also prevent isolation and loneliness. Next slide, please. If there is one good thing that came out of the COVID-19 pandemic, maybe that would be the increase of technology use among older adults. This is a data comparing the frequency of technology use in 2016 to what we have observed in 2020. A lot of older adults has increased their frequency of using technology in different domains. And these gives us opportunity to address isolation using technological tools. Next slide, please. But we also observe a sort of age gap in terms of technology use. And these specific data shows how age groups affecting devices ownership. The most commonly used mobile devices is smartphone, followed by tablet, and then wearable devices, home assistant, and then smart home technology. For the most commonly adopted devices, smartphone and tablet, we still observe that individuals who are 70 and above had a lower rate of the adoption. However, for smart home technology and home assistant, although the overall rate in the population in terms of adoption is much lower, we observe that the age disparities are smaller in terms of those two types of technology use. I have had the experience working with older adults in affordable senior housing and ask their experience of using technology. Individuals of lower income were not able to afford a lot of those devices we are talking about here. Therefore, their adoption rate is much lower as well. And education level could be another barrier when it comes to technology use. It is no news that individuals who have higher education levels tend to adopt technology already earlier when they are working. But for individuals with lower education levels, the process comes a lot harder. Next slide, please. And this is a systematic review on technology-supported intervention to improve older age well-being, including loneliness, isolation, and connectedness. And most of the intervention reviewed have been shown as effective in alleviating social isolation. However, I want to highlight that a lot of those technology tools are not designed specifically to older adults. There could be culture barriers or generational understanding differences in terms of using technology. And I would call for more research working with older adults, co-design technology to meet the diverse needs of older adults. Next slide, please. And this is my own work. Can you please click one more time? Maybe one more time as well. Yeah. So I observe that there is a gap in terms of social contact among internet users and non-internet users over time. This is a longitudinal study that observed those older adults for across 8 years period of time. And among non-internet users, we observe a significant decline in social contact over time. However, internet users were able to maintain their social contact over time. It says something about the fact that older adults, whether they choose to use or not to use technology, that could already be an indicator for maybe health status, for their socioeconomic status, and for their ability to go out and have that kind of human interaction. And this is an interesting finding also in terms of when it's only when internet use has been used for maintaining social contact, that would be helpful for addressing isolation and loneliness. Next slide, please. So lastly, I want to comment on technology is not one size fits all. This is sort of echo back to what Dr. Cujo mentioned about the risk factors of isolation. You see a lot of similar things here, including language barrier, affordability, health concerns, and cultural competence. We cannot just think of technology as a neutral thing. Technology is designed with mind behind it, with purpose behind it. So if we were not to consider these factors, culture and language barriers, it is really hard for us to make it benefit for the population we're targeting. For example, I have been working with the immigrant population in using mobile technology to address their type 2 diabetes self-management. I observed vast difference in terms of Hispanic participants and Asian participants in terms of preference of diet and their exercising preference. So the technology has to be designed to meet their different needs, that we cannot just throw a tool at them and say, these will be helpful and please use that. It won't work. And lastly, I want to mention that technology is not at all a substitute for in-person interaction. Maybe during the pandemic, we have no other choice but to connect online, but it's only when technology is creating opportunities for interpersonal communication is that instead of escaping from the reality, that it would help to alleviating isolation and loneliness. And last slide, please. That's all I have prepared. I welcome questions and comments later on.
Thank you, and I'll jump right in here. My name's Carol Morley. So a little bit of a difference here. I am a director for a 5-county local health department. So next slide, please. If you look at Idaho, not Iowa or Ohio, but Idaho on the west side of our country between Washington and Montana, where it says number 2 and the bright green in the middle of your screen, those are the 5 counties that encompass my local regional health department. We have 5 counties, 13,500 square miles in those 5 counties, a population of just about 110,000, and of that, about 22,000 seniors that are over age 65. When we looked at, you can turn next slide, please. When we look at pivoting, and that's what we really did, our Board of Health across the state in 2018 and 2019 initiated a resolution that said aging is a public health issue. And with the start of that, as we looked a lot in the cognitive world, we know we have cognitive issues, not a lot of good data in our area around cognitive. We had started senior fit and fall classes about a decade ago as a way, especially in our very rural areas, to engage some of our more isolated seniors even then, as a place to congregate together as a social event as well as a fitness event. Our main outcome that we were looking at with our senior fitness is, again, the engagement, but how we keep people in their homes. When falls are the largest contributor to seniors leaving their homes and being into a long-term care facility, maybe never recovering. The cost of falls is tremendous in our senior aging population. So our senior fitness program has been going on really strong. We have 29 sites in 5 counties that serve more than 500 people in our 5 counties in those senior fitness sites. And then as we looked at those gearing up in 2020, and then COVID hits, and we were in a lockdown status in our state, as most states were, no longer congregating, especially our senior population who are at higher risk for severe outcomes to COVID, and not wanting to have any exposure in our senior fitness classes. So we quickly had to put a pause on our fitness work and determine what to do next. We have wonderful, passionate, oops, nope, that's fine. You can go next slide, perfect. Public health staff that we're taking phone calls, like almost daily phone calls from these seniors in these fitness classes that were missing the engagement, feeling very much that they were isolated now and not able to engage in community work, personal, social engagement at all, especially in our rural areas. The isolation that we found initially went to loneliness. The loneliness, when we're looking into talking and frequent screenings of these individuals, we could definitely on their scale and ours determine there was some loss of cognitive function in many of these. And then the worry quickly became depression. And with these almost daily phone calls with these 500 elderly, it became, oh, what do we do what do we do differently? How do we help them through this isolation and loneliness time with COVID, being at home, many of them all by themselves, not able to function at all in that the next world. So we looked to our partners, and we pulled together a small online group, including some of these seniors in these groups, and said, what can we do to help? Next slide, please. So with the input from some of our seniors and our partners, we, our great creative staff, came up with this toolkit, not even a toolkit. What we heard from the people that were out there is they wanted to stay engaged, somehow stay engaged. They loved the phone calls, but labor intensive as it was. They also, we knew we need to keep their brain memory going, their health, their cognitive abilities. We need to keep that stimulated. TV does a great thing, but sometimes you got to do other things other than television. And they also said there's no fun. This is depressing, living alone. There's no fun in this. So this team went out to look at what we could put together for these individuals that are in our programs, to starting there, and how we could help them with some education, contact information, some puzzle books, some pencils, colored pencils, things that they could do at home. They ultimately started to develop own little peer groups that they were calling each other, working on puzzle books together if needed, that they took this and kind of ran with it on their own. Then one of our challenges was, as we were pivoting from face-to-face on what to do, we knew our partners, again, very adequately, very passionate about how they also serve the senior population. Our Meals on Wheels program, we have an Interlink, which is a home visiting and transport company, not-for-profit here. We have our Fit and Fall coordinators. We have community health workers in several of our small rural counties. They all helped us distribute these packets in a reusable bag. They went door to door, hung them on their doors, did a doorbell ring and left, because that's what we had to do at that time, left them a little present as such. And we moved on quickly in how we pivoted. Next slide, please. Prior to COVID, we had been doing some adult well-being assessments. Just to, again, trying to get our anecdotal data, if nothing else, not truly a science research project. We don't have those resources right now, but just asking them how they're feeling about life in general. Resource questions on their health, questions on their mental health, isolation. This tool was developed way prior to COVID, but we continued to use it through COVID, sending them this in the mail so that they could give us an update of how they are doing personally, how they were feeling. Isolation was a big issue in this survey, and the results that they gave us, that the isolation was causing their depression, their mental health status to decrease. So we knew that we needed to keep up the work that we were doing with our senior health kits. Next slide, please. So the distribution partners, again, that I spoke of just a minute ago, our area agents on aging, our community health centers, our Interlink volunteers. What we found out, we had distributed at least 500 to our Fit and Fall people. Shortly, the message was getting around to their friends, and we were getting calls from other seniors going, could I participate in this activities, this fun, this other way of staying connected with other seniors that are homebound as well. We quickly put together 1,000 more kits to distribute in our 5 counties to get that word out into anyone who wanted it. And to this day, we still have seniors calling saying, wow, my friend just told me about this. Could I get on your list to be also a part of this? So what started with fit and fall classes has now quickly rolled into a much larger group of seniors, supporting themselves much more now than we had been supporting those first 500 with daily phone calls. But they're truly engaged and truly appreciative of the work that we did. Last week, we had an interest from one of our fit and fall classes that said, we think it's almost time to restart. So this week, we actually started doing training again, doing it remotely at this point, but we'll be starting up those personal fitness classes again in the real near future. And then last slide, just as a perk, we pivoted only because we had the support from our Lewis Clark Healthcare Foundation, which is here in Lewiston, Idaho. They were willing to believe in us in a short amount of notice that we could use some resources to help our seniors, financial resources. They helped us. They were on the team, put together these packets, put together the work that we did. But based upon that, I mean, we got $25,000 from them, which is a lot of money in our little rural areas to put these packets together. They've come to us again and said, what else can we do? Shall we do some more? So, so exciting to have that financial contribution as well as their community support as we look at supporting senior citizens in rural Idaho. And with that, I'll send this to Sarah.
Right. Well, thank you so much, Carol, and good afternoon to everybody. And I apologize, my camera doesn't seem to be working, but it's an absolute treat to be with you and share some of our work and what we're doing in Virginia to address social isolation. So I'm Sarah Link, and I'm the Director of No Wrong Door Virginia at Virginia Department for Aging and Rehabilitative Services. And I just really want to thank Karen Phillips for the invitation to present and for coordinating this really dynamic session. I've been learning so much already. And my hope is that in the next 10 minutes of this session to give you some informative nuggets, knowledge, and maybe some seeds, some new ideas that will be helpful to you and your networks. So let me go ahead and kick off our journey together with you by telling you a little bit more about No Wrong Door and specifically how it relates to social isolation. Next slide, please. So let's start here with this slide of answering the question of what exactly is a No Wrong Door system. Well, No Wrong Door is a federal initiative under the Administration for Community Living in partnership with 2 other federal agencies that include the Centers for Medicare and Medicaid Services, along with the Veterans Health Administration, for transforming the way people access services in the community. And a No Wrong Door is clearly a systems change initiative and a philosophy that exists in all 56 states and territories across the country, and it exists at very different capacities. In Virginia, we do this systems change type work by leveraging all our existing infrastructure, which includes organizations, resources, supports, tools to improve access to long-term services and supports across all populations and payers. And more specifically, we do this to improve functions and self-directed tools for providing consumers, individuals, and people with options and our choices that are available to them in their communities. Specifically in Virginia, we follow the Administration for Community Living's vision of transforming our system by having a one-stop coordinated network of partners with a single standard process that's objective and person-centered. So in essence, and as depicted on the slide, it's really a way of organizing a community and network of community-based organizations, such as an area agency on aging. There's 25 across the state of Virginia who lead No Wrong Door efforts and coordinate directly with Centers for Independent Living, local departments of social services, as well as transportation and meal providers and other services. Our goal is to better serve individuals, including people with disabilities, older adults, veterans, their families, and caregivers. Next slide, please. So let me turn our attention to the individual and for better serving people, many of who are coming into our system seeking supports who are often socially isolated and contending with many of the ill effects that we've been hearing from on today's sessions about the pandemic. And we've learned from our own research that people find themselves at our metaphorical door and seeking supports and services when they're at critical life transitions of having some type of disruptive life event, like a fall and or the loss of a loved one. And when people come to us, they oftentimes don't need just one support, but they need many and multiple supports that fall into the construct of what we call our social determinants of health. These factors that make up our quality of life in terms of food, transportation, socialization, and health and wellness are part of the work and mission that No Wrong Door does. And we're driven by developing and deploying meaningful tools such as technology, assessments, and resources that can support an individual and improve access to better navigating life's unique challenges. Next slide, please. This past year, Virginia launched a new tool called No Wrong Door Direct Connect. It's the newest self-directed self-referral tool, which can be accessed via our consumer-facing websites. And through Direct Connect, individuals may now directly self-refer to an organization that is a certified partner using our similar technology platform. So let's go ahead and watch a short promo video that is a minute long and it explores a narrative of a person who is looking for supports, not knowing where to turn, and feeling isolated or alone.
When you or a loved one needs assistance, finding the right services and supports can be a challenge. You just don't know who to ask for help. Filling out form after form, leaving voicemails, emails, that on-hold music, it can make you feel like you're all alone, far from the help you need. But you are not alone. No Wrong Door providers across Virginia are available to help older adults, people with disabilities, veterans, and their caregivers and families. And one of the fastest ways to access these providers is by using Direct Connect. For example, if you're looking for support such as social activities, respite, or in-home care, simply input your needs and contact information, and your Direct Connect request is sent securely to No Wrong Door resources in your community. You'll hear directly from the providers you choose, saving you time and effort. Using Direct Connect can start the process in just minutes. Whenever you're online, Direct Connect is there, ready when you are. Fast, secure, convenient. No Wrong Door Direct Connect is here for you.
Thank you. Next slide,
please. And supports can be a form, leaving voicemails, emails, that on-hold music. Alone.
With new technology in place, we also have redesigned our Virginia Easy Access site, which we call our Person-Centered Portal. When Virginians arrive to our homepage, they are greeted with simple invitation to explore some of our resources that make life better. We've designed the site to be a warm, welcoming, and calm experience that encourages visitors to explore and engage with resources in Virginia and beyond. An important part of that experience is that Virginia Easy Access meets the highest level of accessibility, including ease of use and simple navigation on the portal and accessibility that meets level AAA standards. In addition, this site also uses simple language to be at a readability level of no more than 5th grade. Next slide, please. The site also features a toll-free number accessible 24/7, available in 200+ languages and answered by a 211 live call specialist. And this is really a great opportunity for a person to speak with a live person. But for those who are a bit more tech savvy, the site also offers a 24/7 live chat feature, also answered by a 211 live specialist. By clicking into the live chat icon on the web page, the next slide, you can see how this feature will work. Next slide. This slide features a screenshot of a dialog box in which a skilled and trained professional is responding and helping provide a person information on supports and resources that can support their journey. Next slide, please. Now, if we journey back to our homepage site and then click on an icon of social as someone seeking engagement opportunities. Next slide, please. It will then bring you to this page, which is the social page of our site. If you click on the social support category, an accordion menu will expand, showing links to different articles, tools, and topics of curated and rich content. And if you then click on the topic of social connection and assistive technology, it will then bring you to the next slide, please. The social connection and assistive technology page. On this page, we have entered into a creative collaboration with Virginia Assistive Technology System, what we call VATS, and we've developed a social connection assistive technology consultation. And what this means is that an individual can click directly to the icon that refers them to this type of service. So let's go ahead and hear a little bit more from an expert in the recording.
Show, you can make video calls, listen to all of your favorite songs, or watch an instructional video on how to prepare a new recipe. Another possibility for staying connected is a Wi-Fi digital picture frame. Friends and family can upload pictures remotely straight to your device right after they have taken them. Many devices and applications exist to help alleviate anxiety, depression, and loneliness. For example, an artificial fish tank or an interactive companion pet like a cat or a dog looks, feels, and acts like the real thing without the hassle of having to take care of a live animal. A sun lamp or a relaxation app would also be good choices to reduce anxiety and depression. At no cost to you, Virginia Assistive Technology System, or VATS, can help you explore devices, applications, and resources to support social health. For more information, contact Virginia Assistive Technology System, or VATS, at 804-662-9990, or visit our website at www.vats.org.
Next slide, please. Great, next slide. And finally, to conclude, there's another really exciting project that Virginia No Wrong Door team is working on in coordination with United Way Worldwide. We have jointly won the Administration for Community Living's Mental Health Innovation Challenge, mental standing for mobilizing and empowering the nation and technology to address loneliness and social isolation. The mission of this competition was for developing a consumer-focused clearinghouse and matching socially isolated people's interests and needs to customize recommendations for social engagement solutions, programs, products, services, technology, software, and apps, and that have the potential to help curtail the effects of social isolation by enabling an individual to discover, enroll, and/or acquire solutions to fulfill their interests and needs and overcome social isolation. We are currently working closely with the Administration for Community Living, AARP Foundation, and United Way Worldwide to lift up our solutions together into a scalable national model, which will all include many doors of access and supports and be a part of the National Commit to Connect site. A core objective of the national framework, which the Administration for Community Living is to reaching 10 million people impacted by social isolation and helping them and society overall combat the effects of loneliness and social isolation. Next slide, please. In closing, thank you so much for hanging in there and for the opportunity to share some of our work in Virginia. And please feel free to visit our website or to contact us directly.
Thank you, everyone. I learned a lot today, so I hope our attendees also took away some nuggets about all the information shared today. I saw one question in the chat, but please at this time, feel free to ask additional questions that you may have.
So Karan, would you like me to share that that first question
Absolutely.
in the chat? I think it was for Dr. Yu. So the question is, were rural older adults part of the studies that you did, particularly since many do not have broadband access?
Yeah, that's a great question. Unfortunately, no. It is hard a lot of times to recruit both urban-based population and rural-based population. A lot of times, if we were to expand the benefit of technology to rural older adults, it requires like a more specific strategy or more specific recruiting plan among the rural older adults. But it's definitely needed. I think technology possesses great potential in addressing loneliness and isolation in rural settings.
Great, thank you. And as we're waiting for others to potentially weigh in with questions, I have a question for Sarah. So Sarah, I live in Virginia and have an older adult, a parent who is pretty socially isolated right now. And so I'm curious about how you're promoting the easy access, the direct connect. How are those being promoted to residents in the state?
That's great. So we're promoting it through our network of area agencies on aging. So there's 25 area agencies on aging across the state. And we also try to put that out there in terms of our network. So any additional support on getting the word out about our new website, it's newly launched and redesigned. And our direct connect feature, we've been going in phases with rolling it out of getting all of our area agencies on aging into the system, then getting some of our centers for independent living, and then all of our partners. So it's a phased approach. And if you want more information about that, please feel free to reach out to us directly at our email address.
Will do. Thank you, Sarah. So I see a question from one of our Florida friends, Stephanie Myers. Stephanie, do you want to unmute yourself and go ahead and ask your question?
You're asking me with technology after all these Zoom calls. I'm like, oh wait, which button is that? I love some of the things that I've heard today, and it all comes down to how do you get it prioritized and where does the funding come from for implementation? So that's kind of, I'm just trying to get some idea of how did you guys make this stuff happen and make it sustainable?
Well, I'm happy to weigh in to answer. So No Wrong Door is a federal initiative, and we rely heavily both on discretionary grants. We also rely on funding through the Older Americans Act, and as well as state general fund dollars.
Okay. That's helpful. Thank you.
And so Sarah, the funding from Older Americans Act, that's specifically for aging agencies and not public health. So I think that's, you know, that's one of the struggles, I think, is that public health often doesn't have funding for, you know, for the kinds of services that the aging sector does. So any thoughts about that? Or Carol, you know, you could weigh in on this one as well.
Waiting for Sarah. Was Sarah going first?
Go ahead, Carol. I'll follow your lead.
Well, you know, funding, and I mentioned for us, is always a struggle. We don't have the benefit of a lot of state support for these activities. So again, as I mentioned, having a foundation that's willing and was there to step up and help us with our pivot was definitely a blessing for North Idaho. And it looks like they're willing to support us in the future to keep some of this going, even though we're moving that dance back to some of the work that we're doing with our fall classes, which is supported by a contract through our state Department of Health and Welfare through some federal funds. So that part was funded, but of course, when you're in contract world, as all of you know, they wouldn't let us pivot to do something else with those contract funds. So that's where it was so helpful to have the foundation that would step in and help us still maintain engagement with our seniors. And we couldn't have done it without partners either. Our AAA our, Meals on Wheels, our senior networks were critical in helping us get this done.
Thank you. Sarah, did you have something to add?
Sure. And, we really try to leverage our dollars through collaborative efforts. And one of the places where we really try to build those collaborations is with our health department. And I think that's a really important link because we know home and community-based services obviously relates to health outcomes. So I think alignment and kind of, these types of collaborative initiatives are really important for bringing both statewide level to very local level to the table to have real conversations about what's happening in communities. And oftentimes you find that there is really great alignment. And so we try to seed innovation through some of the grant funding that we have by providing them to our area agencies on aging and centers for independent living, because we know that those are really the direct service providers offering those supports.
Great, thank you. And there's one last question. I know we're at the end of our time, but we've talked a lot about technology and the importance of technology. But what if older adults and the families, what if they don't have access to technology and technology literacy? And then how do you address social isolation? Like, the websites are great, but what if they don't have access to technology to access those great resources?
Megan, this is Carol. I'm just going to start briefly. I think that's why our phone calls worked so well, is they still know how to make a phone call, and we didn't have to. We also have the challenges in rural Idaho of connectivity and no bandwidth and internet access, but the phone calls do still work. We've also noticed when we are doing appointments for COVID vaccines, and sign up online, go to online, input your information. It didn't work for our seniors. We stood up a phone bank again and published a number just for seniors so that they could call and talk to someone. So I think a lot of the technology is amazing and wonderful. We're just not there yet in a lot of the parts of our country.
Right, that's great, Carol. Thank you so much. And I think one other thing that can be done, particularly in COVID and vaccinations, and trying to make sure that we're addressing all the needs of older adults, is as your folks are vaccinating and during that observation time, you could implement a quick screening tool. Ask a few questions and make sure that folks are being attended to, and all their social and economic and health needs are being attended to while you're doing that little 15-minute observation. So just thrown out there. I heard that from another public health person earlier this week, so I just wanted to share that. Karan, I'm going to turn it over to you to end things.
Oh, wow. Thank you, everyone. Again, I gleaned quite a bit from this, and I'm not new to social isolation, but this is we're still learning, still a lot of things we need to consider. I really appreciate our wonderful presenters. Thank you all so much for sharing your time and your expertise with us. I greatly, sincerely appreciate that. And thank you for everyone for attending. We will, as posted in the chat, send out a link to the recording and a copy of the slides tomorrow. So please share with anyone that was unable to attend. And thank you.
Thank you all.
Thank you.
Thanks, everyone.